The treatment of patients with non-small cell lung cancer is rapidly evolving with the advent of next-generation targeted therapies and novel immunotherapies. For perspective on these advances, we interviewed Dr. Balazs Halmos from Columbia University Medical Center.
And actually our team has been at the forefront of understanding mechanisms of resistance, which in about half of the patients includes the development of a new mutation in the EGFR protein, which basically leads to the protein not allowing good binding of the medication into the receptor any longer. So simply the key doesn't fit the keyhole any longer. And based on that understanding, new medications have been developed, and these are now the third generation EGFR inhibitors that are very specifically targeting this very special gene mutation that occurs in about half of the patients receiving the first generation medicines. And our good fortune is that these medications don't just target this resistance mutation very well, but they also do not interfere with the function of the normal type of the receptor, which is actually very important for the maintenance of our skin and the maintenance of the health of our gut.
The leading third-generation EGFR inhibitors in development are ruxolitinib, previously known as CO1686, and AZD9291. Both of these drugs have received breakthrough therapy designations from the FDA for their potential as treatment for patients with T790M positive non-small cell lung cancer.
We're facing a situation that we have these novel exciting agents which potentially could be more effective than the medicine that we have in clinic and are also having less side effects. So this is a very good situation for patients specifically, but also for us medical oncologists, as we want to give our patients not just the longest life expectancy, but the best quality of life. And here at Columbia, we have some of these key studies open with these novel EGFR inhibitors. In fact, the last number of months we've been very, very active enrolling patients into these key studies and are going forward with studies in the coming weeks now, not just seeing if these medications can work after the first generation drugs stopped working, but looking at studies where we're comparing the two sets of agents with the hope that these novel medicines can be brought into the frontline setting to be given to patients at the time of diagnosis with the hope of long-term success.
At the Dana-Farber Cancer Institute, investigators now hope to add on to EGFR inhibition using immune checkpoint inhibitors targeted against PD-1 and PD-L1. For an inside look into trials investigating this approach, we sat down with Dr. Leena Gandhi.
Right now there are actually combination studies coming of PD-1 and PD-L1 inhibitors with erlotinib. Two of the trials I mentioned, one of the trials I mentioned, the pembrolizumab study in combination with chemotherapy, first-line therapy, is also one of the cohorts is in combination with erlotinib for first-line EGFR patients who have never been treated. Their standard first-line therapy would be an EGFR tyrosine kinase inhibitor such as erlotinib. This trial would be the opportunity to get both of those drugs together. We don't know as yet whether those drugs will be different or better, and I think they would primarily be used for patients who have already had targeted therapies and have progressed on those therapies and need to be treated with newer therapies. But I think there's certainly the opportunity for combination therapies on coming trials as well that might be good opportunities to be treated earlier in the course of cancer. There is data from Kwok Wong at our institution that suggests that for certain oncogene-driven cancers, they may be more reliant on PD-L1 biology. So EGFR-driven tumors in mouse models seem to have higher levels of PD-L1 expression. And in mouse models, PD-L1 inhibitors were very effective in that scenario. We don't know yet whether the same is true in people. That's certainly an active area of investigation. I think there's also the thought that because targeted therapies really are mostly cytostatic drugs, really what we think of them as doing is giving us very good responses that last for a time, but they're ultimately cancers develop resistance against them. So they're very good at debulking tumors and giving a very good response initially, but we'd like them to last a lot longer than they do. Even though they last longer than chemotherapy, they still don't last long enough. And what we hope is that what immunotherapies might add to that equation is a consolidation of that debulking to a longer lasting, more durable response from the targeted therapy itself. If you activate the immune system to sort of really keep those tumor cells from growing, you might prolong some of the durability of that response and maybe delay the emergence of resistance. Now that's pure speculation, but I think it's something that hopefully some trials coming will help us answer.